And you're on, Ryan.
Awesome. Well, I think that this is exactly how it's supposed to be, with James and Stephanie here from their kind of high level view. We can go through this content. James and Stephanie were both really responsive to some email chains that I was sending out around drug trends and different things I was seeing in Vermont. So this is really um, I'm getting a kind of an echo in the audio. It went away. Um, so this is a constantly evolving training that I've put together over the past few years, focusing on overdose prevention. I'm not a clinician. I'm not a social worker. I'm a person in recovery from a substance use disorder, a person who's alive because of naloxone, and I've really just used my negative lived experience and positive professional experience to develop this stuff and support people going through what I once went through. Um, and the more that I worked within addiction treatment and recovery systems in New Hampshire, the more that I landed on harm reduction, because harm reduction is really about compassion and love and faith in people. And, you know, it really has given me a way to stay engaged with people and to keep people alive. And in a minute, I'm going to share a little bit about my story, and then we're going to roll into some content about harm reduction. It's kind of a universal concept, and then more specifically around working with people who use drugs. And then we're going to look at how that relates to recovery and recovery oriented systems. And I think that there's going to be hopefully a little bit of discussion there. I'll probably briefly touch on syringe services programs, like the programs of the HIV HCV Resource Center. They're also called needle exchange programs, but the reason they're called syringe services programs is because we offer a lot of different services beyond just syringe access. And we're going to get into that a little bit and how helpful that is in rolling out a public health framework to address the overdose crisis or the addiction crisis or the mental health crisis or the COVID-19 crisis or the viral crisis or the potential HIV crisis. This is a syndemic, and it's really about, looking at science and research and evidence. And that's really what harm reduction is all about, is education, conversations like this, and really looking at what's objectively going on. I know y'all are really interested in rising rates of stimulant use and how to address that. So we maybe won't beat up opioids all that much, because I think at this point, most of us have done a nasal spray Narcan training, and the meth stuff is pretty new to the Northeast. I was born and raised in New Hampshire, and when I was using, you really didn't see a whole lot of meth, and when you did, it wasn't all that great. Now, as I've talked to other folks in law enforcement, the meth problem is real bad, seems to be getting worse. And then we'll kind of wrap up with some conversations around supporting people who use drugs, different techniques to engage with people. And this is where I think some solid conversation will come out around potentially rolling out response teams, overdose follow-up, other types of outreach services that, don't focus on criminalizing people and supporting people to find recovery. But really, as I kind of alluded to, I'm a person in recovery. I both used and sold drugs for over 10 years in New Hampshire, where I was born and raised. And I've been in recovery for 5.5, it'll be 6 years in December. I was born to a, middle class family in Hampton, New Hampshire, grew up on the beach, never went without anything. But I definitely had some mental health issues, some trauma issues, but I didn't have language for that. I didn't have mental health education or ideas around emotional expression or identifying role models. I really didn't know much about mental health aside from what I saw on television. And I really only knew about drugs, the fact that people only did them because they were losers and that people were going to try to jump out and give me them for free at some point. And both of which were not true, but when I got into high school at 14 years old, I had a lot of anxiety, a lot of issues. I was at that point being neglected at home because of parents' alcoholism. So drugs made a lot of sense for me. And first tried alcohol and then oxycodone or Oxycontin. And then I tried cannabis and went on through. But this was in 2004 when almost every medicine cabinet of the kids I went to school with had some it in it. And so I went through high school using and selling drugs. And that served a purpose in my life. You know, people don't do things for no reason. And I found that drugs were doing for me what society wasn't doing for me. And once I realized I had been lied to about the dangers of cannabis and other things, everything that I was told about drugs was discounted. And I found myself on the internet learning about different ways to change my state of mind. And then, that gave me a sense of comfort and ease and the ability to connect with people. And then I found selling drugs, and that really gave me a sense of purpose and a sense of family and a sense of connectedness to people. And um, really, when I tried recovery time and time again, there was huge gaps in my life. And I would always go back to different behaviors that would serve a purpose to fill the gaps in my life. And it really wasn't until my life was saved for the third time by first responders. So the picture on the far left is me in 2010 in book, about to do 30 days and withdraw from benzos, opiates in jail. The next picture there with the call police sign is me injecting cocaine, living in a tent. Much of my adult life, I was homeless, and that too served a purpose, whether I was engaged with a criminal element, living in homelessness, using injection drugs. That at some level was serving a purpose in my life. And it really wasn't until I identified the the benefit of these behaviors that I was able to really replace those behaviors. And really in 2014, these guys with me in the third picture to the right there, Jed and Craig, they're Hampton, New Hampshire Fire and EMS. I was doing some compassion fatigue trainings in house for first response about overdose and burnout, serious trauma, and at the end of one of the sessions, these two guys came up to me and said we were actually at that last overdose in 2014, and we connected. We did a bit for the newspaper, and it really highlighted the healing power of storytelling and a tradition that our ancestors have used forever, really. And so we really came together and built empathy. Um, and because of naloxone, I'm alive and healthy. I come from a social circle who's alive because of naloxone. And now I'm working, as you can see here on the right, operating the Claremont Exchange. We're a legal syringe services program, and we offer services to people who use drugs or at risk for overdose, death, and disease. And time again, my recovery journey has been about healing through storytelling and also connecting through shared experience and using my life story to help others in some fashion, whether that's, sharing advice or, mitigating harms because I now understand the dangers of their behavior. And I'm only alive and healthy because not only for naloxone, but harm reduction. Two specific people came into my life when I was about 20 and starting to inject drugs, really chaotic, full blown use disorder. And they educated me about disease and overdose and gave me sterile syringes, even though that was illegal in New Hampshire at the time. And I didn't really get it. I had another friend who would deliver me syringes and sit with me while I was using alone in my early 20s. And because of those people educating me and providing me services, I never contracted HIV or viral hepatitis. I have a clean bill of health. I did some irreparable damage to my body through using drugs long term. But generally, I don't mind going for a yearly physical. I don't have any diseases from injection drug use, and recovery is awesome. And I've really enjoyed it a lot, and I've kind of built a career out of it. But I brought up the term harm reduction, and I know that folks on this call are pretty familiar with concepts of, syringe services programs or overdose prevention, or, different types of drug checking programs, or even what you see here with the supervised consumption site in Canada. Harm reduction seems pretty radical to most of society, um, because we kind of have a interesting view of drug use kind of throughout our society, and we'll get into that a little bit. But really, a universal philosophy and a concept that we use every day, and first response especially uses harm reduction every day in their life. It's really just practical strategies and ideas aimed at reducing the negative consequences associated with risky behavior. Anything human has risk associated to it, whether that's breathing air, walking, driving a car, injecting methamphetamine. Not only does any human behavior have risk associated with it, but any human behavior serves a purpose. We don't do things for no reason. So, I really don't want my friends jumping out of an airplane, but if they do, I want them to wear a parachute. It's harm reduction. I don't want my friends and family to drink excessively the drug alcohol, but if they do, I want them to be at a supervised consumption site where they employ harm reduction and make sure people aren't driving under the influence. We have consumption sites in our society. They're called bars. We use them all the time. And I'm sure that y'all can think of a number of ways you use harm reduction in your day to day life. Really universal concepts throughout medicine and public health, but harm reduction as it relates to drug use. Would somebody like to read this from Harm Reduction International just to break up the sound of my voice a bit?
I can do that, Ryan. According to Harm Reduction International, harm reduction is a set of evidence-based practices that minimize the negative impacts of drug use and ineffective drug policies. Harm reduction is grounded in principles that protect human rights and improve public health. It incorporates a wide array of approaches, including abstinence, designed to meet people where they are and offer opportunities for people to improve their health and well-being.
Thank you, Melanie. I like it a lot. It really just objectively talks about, the behavior of drug use. And there's really no recorded human history without drug use. And as far back as recorded history goes, humans have used intoxicants in some way. And for most of human history, drugs were actually celebrated and considered to be sacred or religious or healing. Known use of opioids in humans was in southern Iraq about 5,000 years ago, and there was a religion formed around the opium poppy. And really, though, in our lifetime, we really only know ineffective policies like prohibition. The idea that we can prohibit the behavior of drug taking and punish people to change their behavior, but that's really ineffective, and it's also contrary to everything we know about substance use disorders, because we define a use disorder as continuing to fight negative consequences. But we've kind of developed a society where our response to substance use is to offer negative consequences. And harm reduction is kind of a response to that. And oftentimes, harm reduction is born out of things happening. It's usually a negative event around public health. Harm reduction kind of manifests and insulates people from structural inequity or systemic injustice, and it focuses on human rights. And so, if there's no human history without drug use, there's no human history without drug users or people who sell or share drugs. And really, what we've seen over the past 100 some odd years of prohibition is expanding addiction rates, overdose rates. Drug use has proliferated, and it has had a negative impact on public health. And so, harm reduction looks at developing a public health framework to meet people where they're at. And it's a wide array of approaches, including abstinence, because we all have a relationship to drugs, and avoidance of drugs is a relationship to drugs. And we really need to understand that drug use is kind of ubiquitous. I'm drinking a really strong coffee today. It's been a long week. Some of us may use nicotine or cannabis or alcohol or who knows what, but people do it. It's harm reduction acknowledges that. And it also offers opportunities for people to improve their health and well-being. And the work that I've done with H2RC, that's what we'll call the HIV/HCV Resource Center, has been really a privilege to meet really marginalized people kind of living in the shadows of criminalization and discrimination and empower them. Harm reduction is really a movement of empowerment and showing people dignity and respect and allowing them to define their own goals to improve their health and well-being. And so we pretty much just a little bit of a boiled down definition. And harm reduction with a capital H and a capital R, you'll kind of see some other stuff through Harm Reduction Coalition, where you really see it as like a social movement or a movement for personal liberty built on the belief in and respect for the rights of people who use drugs. I really never thought of myself as facing discrimination. I have a fair amount of social privilege, but I faced a lot of discrimination as an injection drug user, living in the shadows of criminalization. And it wasn't until I was in recovery for a few years and found the harm reduction community that I realized that a lot of what we know to be true about drug use and addiction is contrary to how we address it in our society. And action strategies look different place to place, state to state, country to country. But really, you kind of see some specifics in the strategy right now. It's access to cost-free naloxone, also known as the name brand Narcan. That's kind of why we're here. At face value is to learn more about overdose prevention strategies, but we really need to expand overdose prevention to include all drugs. And really, that's about harm reduction, creating a pathway of recovery and a pathway to recovery for people, and giving people treatment options and treating use disorders or drug use in general as a health condition. But really, we call it a disease or a condition or a disorder, but we treat it like a crime. And even treatment systems are largely punitive, and there's contingencies and ultimatums, and it's really doesn't make a lot of sense for people. Treatment saved my life. I went to rehab 4 times. I went to a number of detoxes. I went to a Suboxone doctor who kicked me off the program for using cannabis. I had a lot of negative experiences in treatment, but ultimately it was all I had. And they told me, go to whatever you can go to. The first program that accepts you, go to it. And that's not healthcare. That's just, you know, kind of where I'm at with it. So harm reduction is about honoring people's agency and autonomy and allowing them to make decisions on their life and giving them options for. And that also includes giving people housing and offering housing first models. So giving people what it is they need to survive as a human being without contingencies or ultimatums. And so housing first models look at giving the most at-risk or vulnerable people in our society housing, even if they're using or engaging in sex work or other behaviors. And what we see in parts of America, and especially in other countries, when you house them, the other services work much better. They're accounted for, they're safe, they're practicing sleep hygiene and other types of, daily living stuff, and it works out really well. And in a nation that prior to COVID, we had over 500,000 unhoused Americans every night and 1.5 million empty houses, we really need to look at how to house people and treat housing as a human right, because housing is arguably the number one determining factor for successful recovery. And in New Hampshire, I see time and time again people that go to addiction treatment and return to being homeless, people that go into incarceration and return to homelessness. And we know that this is a recipe for recidivism and failure, but we act like people need to be abstinent or to modify their behaviors to give them services, housing, food, medicine, healthcare, etc. And that's true for the people that I serve in my job. A lot of my folks are on house, they can't access services for fear of punishment, and their fear is pretty valid. And so it's really about looking at drug policy and criminal justice reform and seeing, how can we keep people alive to enter recovery? Because, dead people don't enter recovery. And what I see is, generations of people who are self-medicating, who are having a hard time coping with the world, and they're using drugs to cope in their day-to-day life. And I really identified that with that. I believe that if I had not found drugs and self-medicating, I would have taken my own life with suicide. And so it's really about creating a way to intervene in drug use that doesn't traumatize people and re-traumatize people. And I've I'm not going to do the story thing yet, but I think it's about drug user rights and offering them health care. A pathway to healthcare for people who inject drugs are syringe services programs, and we're going to get into that in a little bit. On-site drug checking is like offering people fentanyl test strips to test their drug supply, because in an illegal market, it doesn't come with a label, or, unless you have a really good dealer, you're not getting like a fact sheet from the FDA. It's just basically whatever they want to give you. And so giving people drug checking equipment like reagent test kits and fentanyl test strips and other types of immunoassays or reagents, people can figure out what it is that's in their bag. And as somebody who spent, most of my using life in sales and distribution, I usually think of this as like an economics thing. There's a demand, so there's a supply, and now the supply is getting crazy. And it's really a market that will fix itself if you give people the ability to check their supply for the presence of fentanyl or other unwanted adulterants, because people can go back to their supplier and say, I don't want this cocaine because it has fentanyl in it. And I've seen that in the Seacoast rolling out some pretty comprehensive drug checking programs. And that comes back to something that's been in the news more and more on supervised use. And we may see overdose prevention sites or injection sites in other countries. But here in New England in 2020, when I say supervised use, I'm just talking about creating a culture of people who don't use drugs alone, who, are accounted for and who just say no. KNOW. They know themselves, they know their limits, and they know the risks, and they know their drugs. And that is a movement of empowering people through harm reduction. And it's really important to emphasize, don't use alone, because all the times I've lost a loved one to a fatal overdose, they were alone and behind a closed door because of stigma. And stigma is important to talk about, and it's really a nice way to talk about discrimination and oppression. Really, it's do this for people that are, we're generally here to help and to figure out how we can intervene in this. And before I get too further high up on my soapbox, does anybody on the call have any questions or comments about anything that we've gone over so far?
Hi, Ryan. It's the other Ryan. I just kind of wanted to highlight the importance of housing, particularly for people being successful in any kind of medical treatment. So, one of the other services offered at the agency Ryan and I work for is medical case management services for people living with HIV. And so we have whole programs that are funded at a federal level to help people living with HIV stay housed, because the data shows that people who have stable housing are going to be much more successful staying engaged in medical care and staying on treatment and keeping their viral load suppressed. So I would just like to really highlight the importance of housing for anybody that is trying to get into recovery or seek, MAT services or just any kind of services. It really is, housing is such a critical component, and it is really unrealistic to expect that people who are unstably housed are able to be successful in treatment. So anyways, I'm glad that you brought that up, and I just kind of wanted to support that statement.
Well, thank you. Great. So as we can see here, these are kind of some disclaimers that harm reduction isn't about saying legalize it and do whatever you want or having a free for all. It's about creating a public health framework and meeting people where they're at and empowering them to make better choices. And it's not about proliferating drug use or getting people to start using. It's about simply acknowledging that drug use is a thing that happens, but not condoning, endorsing, or encouraging it. But it's creating a pathway of recovery and to recovery, because that's really, I think, the overarching goal is to have people who are struggling find recovery. And I almost always at this point in life go to Samson's definition of recovery, which is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. I love this because anybody can use it. I can use this at 5.5 years sober, and I can find anywhere I can improve by 1%. I find, wherever and however I can improve by 1%. My full potential is limitless, and I can always improve my health and wellness in some way and be more self-directed. But for a lot of people, especially right now in the times of COVID-19 and the economic recession and everything that we see in our day-to-day life, their full potential right now may include self-medicating or drug use. And it's really frustrating and challenging. But we really need to acknowledge that drug use falls on a continuum and that we're all born abstinent of drug taking behavior. Of course, there is neonatal abstinence syndrome, but really, we're born of that abstinent of drug taking behavior. And the very large majority of Americans will experiment, whether that's alcohol, cannabis, nicotine, caffeine, etc. And fewer people move along this continuum. And some people do get to a point in life where they have the moderation conversation, but fewer and fewer people are considered regular, heavy, or chaotic drug users. If we use the lens for alcohol with a lot of this stuff, it makes a lot more sense. But we really think of illegal drug use as black and white, as abstinent or chaotic, but really only 16% of, well, I won't say only, it's growing. So 16% Americans meet criteria for a use disorder. But really, the truth is that most people who use drugs don't have a use disorder. This thing, a lot of the most up-to-date research on long-term recovery outcomes for use disorders show that moderation is oftentimes the most common outcome in a cross-section of people. And also, there's this kind of aging out process or natural recovery that happens between ages of 25 and 35, maybe a little after, where hormones change, life fills up, and people moderate or stop use on their own. And a small percentage of people who are currently in recovery ever went to treatment. But really, we emphasize this acute care model for treating use disorders, and we want to people away, and hopefully they sort themselves out. And we really treat this, we want people to go from chaotic use to abstinent in 28 days or 90 days or what have you. But when we start to define people's goals, we're kind of failing them. And really, if we want to talk about use disorders as a chronic health issue, it's about incremental change steps, any steps in the right direction. And really, that includes a whole health approach and providing services to people who use drugs chaotically beyond treatment. And that's, healthcare, that's housing, that's the social safety net that really isn't accessible to drug users. And, plenty of people in the United States are in abstinence-based recovery, some are in moderation-based recovery, some are using medication-assisted recovery. But it's really about celebrating success. But what we do is we emphasize treatment, clinical care, multi-billion-dollar industry, acute care. We tell people to meet diagnostic criteria so Medicaid will pay for it. They hit a bottom, kind of the people that first responders are seeing on a regular basis. And we think if they go to wherever it is, the treatment program, they're going to come out and have a community life where they have a sense of belonging and housing, and they love their life. And, that was true for me. And I have a fair amount of social privilege, certainly have spotty upbringing for sure. But when I found free, I was able to be housed by my family. I was able to find work because I wasn't a felon, even though I've been arrested with felony drugs multiple times. Straight cisgender white male. I got a lot of deferred sentences and alternative sentencing. And after 4 tries, worked for me. But working in addiction treatment in New Hampshire, I've seen people who have done this dozens of times, and it's really frustrating because it doesn't work for the people who need services the most. And it's definitely gotten better in New Hampshire, and I'm learning Vermont systems more and more as far as addiction treatment. But the people that need the services the most aren't able to access them because their need is so high. So really, it's about developing recovery-oriented systems and making sure that the needs of everybody every individual are met on their terms. And really, in this model, you can kind of think of the world around you as like a pie graph, or your most important stuff. And for most people in recovery, that treatment and recovery circle, there wasn't clinical services. And so for some, it might be yoga or church, or really could be a number of things. Everybody's different, but really, if we take this whole health approach that we see from like earlier ways to work with people living with HIV, if people can work on what it is they want to work on, the experience of many people in long-term recovery is that once the world around us had filled up, drug use didn't fit back in. And in my professional life, I've flushed heroin and meth down the toilet. I've intervened and handled drugs a number of times. I've been able to hand Manchester PD days of drugs working at the Safe Station program. And it just didn't make sense for me because I was no longer self-medicating, and I had a sense of belonging and connection and well-being. And unfortunately, we tell people who use drugs that they need to be abstinent before they can get health care or social support or work or school or come to church or access food services. And this system here works a lot better for people. And it's really, you can't have a recovery-oriented system without harm reduction, because harm reduction, the goal is for individuals to improve their health and well-being, and that kind of spills to the community around them. So it's for individuals and the community around them, because we're social creatures, and addiction is really characterized by isolation and disconnection. And so we offer people with use disorders isolation and disconnection and contingencies and ultimatums. And it's really contrary to what we know about the disorder. And harm reduction also looks at the roles of discrimination due to poverty, racism, classism, sexism, homophobia, isolation, trauma, and other inequalities in drug-related harm. And most addiction treatment and recovery systems don't acknowledge this. They kind of tell people that this is a disease with no known cure. You're the problem. Do the step work, do the this, do the that, and it'll sort itself out. And we tell people not to move because you can't have a geographic cure. And it's very prescriptive when we define people's goals for them. But harm reduction, we're not going to address that cluster of inequities in our society today or tomorrow. We can start by showing people dignity and respect and empowering them to reduce harm in their life and harms to the community around them. And really, the art of harm reduction is really about faith in people and showing them dignity and respect and empowering them. And really, I learned pretty young from my mom that, the people that seem to deserve love the least need it the most. And, drug users are beautiful, creative people who are self-medicating. And oftentimes they don't understand the purpose of their behavior. So they can't connect their consequences to that behavior, because behavior is serving a purpose in their life. And so it's about, engaging language and asking open-ended questions and validating people's experience and their emotions and having them find their autonomy and their agency to decide what it is they need and what they want. And for whatever reason, our society, especially medicine, doesn't think we should give people what they want, which is like kind of weird. Our society is really obsessed with punishment and being prescriptive, but really harm reduction and recovery oriented systems ask, empowering open-ended questions. What do you want your future to look like? What do you want to work on? And really, when I'm working specifically with people who are using drugs, it's a really eye-opening question to ask. Is it your goal to be abstinent? People assume that when they access addiction treatment that their goal needs to be abstinent. And largely that's true for a lot of people's experience. Things are changing with harm reduction, but it's about asking people, what are the benefits of your drug use? They probably know what's bad about the drug use. They're seeking help. Sometimes it's about asking, what motivates you to use this drug? Can you make a safety plan or yourself that includes moderation management? That M word, I never heard in addiction treatment. Moderation management has a lot of promise, and it really empowers people to analyze themselves in a way that they never have before, because they're basically told their drug use is bad and they need to stop, but they can't stop. And so moderation management techniques really open the eyes of individuals to see like, oh, this is kind of what's on, and then that helps them to define a wellness plan that makes sense for them. And as you're probably picking up at this point, harm reduction is a framework for working with people who use drugs, and we strive for any positive change, any steps in the right direction, as long as it's driven by the individual, as long as the person's defining their own goals and they're supported and there's no punishments or contingencies or ultimatums, there's no coercion. Sometimes people with the Claremont Exchange and the exchanges for H2RC, there's this weird moment where they don't get it. Like they want to give me a health insurance card, or they want to fill out forms, or they're like expecting me to ask something of them. And harm reduction is just meeting people where they're at and being present and bearing witness to suffering, but also being an open ear and an access point to all sorts of different services. And as we dig a little deeper into harm reduction as a framework for understanding drugs, harm uses science and evidence and research. And I love that James and Stephanie are on this call, because they're kind of high level, looking at, trends, as they said, from 30,000 feet up, what's going on, and how can we help with the big picture. And it's really cool to be here today and engage in this conversation. 6 years ago, I could barely feed myself. I was living in a vehicle, shooting heroin and cocaine every day. And I had a lot of people telling me that, a drug is a drug is a drug. And if you're just going to smoke pot all the time, there's no point. But harm reduction acknowledges that some drugs are safer than others. And harm reduction celebrates people who want to stop using fentanyl and use cannabis or other alternatives, and celebrating any positive change. And also, harm reduction looks at the context of drug use, looking at not just the drug, how is it used? What is it? Is it an opiate, a stimulant, a benzo? But looking at the individual or the set. And that's kind of what someone brings to the table. So their health, their mental state, their cultural identity, their sense of belonging. And that's a big part of drug use, is the expectation and motivation for using the drug, but also a sense of belonging. And if we look at things that we don't like in our society, like sex work or gang activity or drug selling, there's a lot of secondary benefits to that, a sense of belonging and protection. And it really has to look at, the bigger picture, and that extends to the setting in which a drug is used. So stressors in someone's life, the socioeconomic impacts on drug use are very clear. And really, when I think of use disorders today, I think of it so as a measurement of how somebody is impacted by the war on drugs. Like, how insulated by privilege are they? Because we see people in our society that use drugs with impunity. Rich people, Wall Street, Hollywood, et cetera, et cetera. And it's really about the social and cultural attitudes towards a drug and its users. So we worship rich people who use drugs, and we listen to them on the radio every day. We see them on television, but we vilify the people in our community with a use disorder. And we say, this, that, the other thing about them. And really, it's about looking at the bigger picture beyond just the drug and telling people why it's bad, but analyzing the person, the group, and the community in which they live. And this is a lot easier to digest using like alcohol as a lens for this. But Norman Zinberg did a lot of great work for this, and a lot of our understanding of addiction is based on harm reductionists like Norman Zinberg and Bruce Alexander and Gabor Mate, and really, really smart addiction scientists. And so, Melanie, I got your message. Are we going to 11 or 11:30?
11:30.
All right, perfect. Because your message kind of scared me. I thought I only had 3 minutes left, and I was doing really poorly on time.
No, you were 23 minutes in at 10:42, and we have 40 minutes left if you want to leave 10 minutes for questions.
Okay, that was the whole. All right, thank you.
Sorry, I didn't write it very well. Sorry about that.
It's all right. Does anybody on the call have a comment or question so far, or anything you want to bring up? All right. So, hope you're still with me. And this is a really important work when we talk about harm reduction. disease, because a lot of the reason that the funding is going to programs like the one I'm expanding and working with, the cost benefit is in preventing disease, because HIV, while it's not curable, with the newest medications for HIV, people can be undetectable and untransmittable, U equals U, and HIV is no longer a death sentence, but unfortunately, 1 in 7 Americans don't know their HIV status, and there's been some more recent clusters of HIV around injection drug use in the LGBTQ plus community, specifically trans folks and men who have sex with men, very marginalized populations that have a hard time accessing services. And so harm reduction programs like the ones with H2RC provide disease testing so people can know their status for HIV and viral hepatitis, and encouraging people to get tested at least once in your life for HIV. And more recently, the CDC released new guidance for hepatitis C that said every American adult should be tested at least once in their life for hep C. Because based on the newest data on surveillance or lack thereof, it's estimated that 1% of all adults in the United States are living with an hepatitis C infection. So 2.3 million Americans. And every woman who is pregnant should be tested for hepatitis C now, so that it can be prevented from being transmitted to the infant. And so these outbreaks of HIV, hepatitis C, and also other infections like endocarditis and cellulitis and other infections from injection drug use. So is that you have lack of access to disease testing, lack of access to services in healthcare, clearing out of homeless encampments, or lack of housing, and synthetic opioids. Synthetic opioids don't last very long, and people are injecting more. And then that is really aggravated by lack of access to sterile syringes, because people are going to use injection drugs in one form or another. And when you restrict access to syringes, you really aggravate the risk for HIV, viral hepatitis, and other infections in the community. And we're really talking about bloodborne pathogens, but these diseases can be transmitted through sex or snorting drugs in other ways. But the highest risk are injection drug users. And so it's really about knowing your status and getting connected to treatment. And that's what the majority of work with H2RC is providing case management services. And people can be cured of hepatitis C with the newest medications, and they're much cheaper now too. So for most of history, people have been told you have to be sober for X amount of time before you can access hep C treatment. But Medicaid will pay even without somebody being abstinent, because the new medications for hep C are so effective that you don't need to stop drinking or using all the time, and you can cure your hep C without any sort of documented abstinence, because Medicaid would rather pay for multiple rounds of medication than a lifetime of chronic hepatitis, liver cancer, and really late stage hepatitis C is a really horrible disease to watch take someone's life. I've had the really sad opportunity to see a few people living with late stage hep C, and it's really horrific. And I think that more people need to understand that this is part of this syndemic. We have COVID-19 pandemic, crisis, addiction crisis, etc. There's a lot of other public health crises within this that is really scary. We are really at high risk for an HIV outbreak, and we at the agency are trying to figure out how to roll out disease testing again and still be physically distanced. A lot of people don't have access to healthcare because of COVID-19, and there's a lot of experts who think Vermont and New Hampshire may already have HIV in certain communities, and there has certainly been new cases popping up on both sides of the river. But the way to address that effectively are certain services programs like the programs of H2RC. 30 plus years of research will tell you that they promote public health and safety. They protect first responders from needle stick injuries. They do not increase crime or drug use, and have been shown to decrease crime and drug use in a community. They're cost effective. The syringes cost about 7 cents. a case of endocarditis is at least $250,000. You know, the cost benefit is there, and that's why the federal government has endorsed this. And especially more recently, Surgeon General Jerome Adams has openly endorsed syringe services programs, because while we try to mitigate COVID-19 and other epidemia, syringe service programs are a way to meet the most vulnerable and mitigate the spread of infectious disease. And evidence shows that people who inject drugs 5 times more likely to access treatment and 3 times more likely to stop injecting if engaged with an SSP. And I've seen that a lot the past 9 months being out here. Moved to the area from the Seacoast, working in Manchester and Nashua. I'm kind of the new guy in town, and you know, things that are sorry, my throat's kind of dry. Things that are normal to me in my day-to-day life, 211, hub and spoke, MAT options. People aren't aware of what I'm aware of. And so the most basic conversations to me, having a coherent conversation with somebody living in chaotic drug use, the lights come on. And with COVID-19, I think the best silver lining has been telemedicine and access to medications for opioid use disorder through telemedicine. I saw transportation barriers go away, and I saw very introverted, traumatized people access treatment and stop injecting. And the first few months of running the SSP, I would always be fearful when people stop calling on a weekly or bi-weekly basis, but time and time again, I hear that they're in recovery. I'm hopefully going to be meeting up with one of my first participants later this afternoon. He wants to buy me lunch. He is really into this. He supplies mostly Narcan for people in Newport, New Hampshire. Doing great. I saw him the other day to give him some Narcan and some other supplies for people he knows in Newport, and he was like, "Can we please meet up and do lunch?" He was just so grateful for this, and I don't really think of it as that heavy. It's just, what you, and it makes a lot of sense to me. But for much of our society, these are like radical concepts, and really the beauty of this is that there's multiple points for engagement in services, and the syringe is the point is the point, and that's the engagement tool. So people come for the syringes, test strips, Narcan, sterile works, disease testing. Sometimes we have like donation food or clothes or things like that. But in the process of engaging with an SSP, they have access, they're the potential for crisis intervention, wound care, disease testing, overdose prevention strategies like this, access to health insurance and healthcare, and referrals to services. I swear it's on a COVID cough. I just have like this piece of granola bar in the back of my throat. So that being said, when we think of it like this, it's a lot more than giving out needles, because there are programs that's really emphasize just go out and give them the stuff they need, the supplies, and I can go out in the community and hand someone works and supplies and not with dignity and respect and be cold or prescriptive or evangelize them. That's not harm reduction. That's just giving people needles. But the art of harm reduction is about empowerment and, watching the lights come on and people going through that kind of natural recovery process in a kind of quick fashion sometimes. Not always. I have people who use the program who may use drugs forever, and that's their full potential. That's fine. I'm not really concerned with where they're at, as long as they're, having open and honest conversations and creating a space for people to be. And something that we're rolling out starting this Monday on the New Hampshire side, but obviously open to people who are on the other side of the river, is a mutual aid group called Harm Reduction Works. Giving people a space to come and who work in harm reduction to process what we see, because I have a high school diploma, but I feel like I practice medicine some days, because people don't have the ability to talk about things with anybody else, and they see me and they want to show me their infection, talk to me about their healthcare issues. And something that we're working with Dartmouth on is developing telemedicine healthcare for people in these situations. So we've been able to connect 2 people to Dartmouth's infectious disease team through telemedicine for access to things like antibiotics, because I don't say to people when they show me their infected wounds or things like that. But, you know, it's working. I have collected not the best, most comprehensive data, but time and time again, I'm seeing this is working really well and been expanding into Springfield for sure and other parts of Windsor County. So hopefully we can look at harm reduction programs as we try to figure out how to reduce overdose deaths, because these are the most effective tool in reversing and saving lives from an overdose, because the person who's most likely to reverse an overdose with naloxone is a person who uses drugs. So providing services for people who use drugs is really getting the naloxone in the hands of people who are going to use it. SSPs beyond 30 plus years of research are endorsed by all these people, institutions, agencies, organizations. I'll sometimes say, if you don't want to agree with me or the evidence, do you like any of these entities? Like, you know, I might like some of them, might not. But there's never been actual research that said SSPs are a bad idea. And they're really important right now in the face of the opioid crisis. So that's pretty much the harm reduction syringe services at chunk of this. I spent more time on that because, you know, I think we all get opioids at this point. But does anybody have any questions or comments before we breeze through opioids and land on some stimulant stuff and then talk about next steps?
I think you're doing great, Ryan.
Thank you. So, you know, New Hampshire is typically second or third in overdose deaths per capita. We've had many wonderful politicians call New Hampshire many great things based on our addiction rates, overdose rates, mental health rates, systemic equities. And, you know, it's really, I sometimes really jaded working with Vermont on this, just looking at the numbers and coming from working in Manchester and coming over here. And it's, you know, they're not just numbers, they're human beings whose life matters. And what we really see with prohibition and the war on drugs is this underlying theme in our society where people believe that death is an acceptable consequence of using drugs. We are programmed to believe that if people decide to use drugs, a potential and acceptable outcome is death. That is BS. People who use drugs do not deserve to die. But we still have systems that, you know, make the overdose crisis worse. CDC predicts 75,000 Americans will die of a preventable death. Overdose death is 100% preventable, because that's just a number we can't really comprehend. What does 75,000 people look like? Maybe in a stadium. But it's people whose needs were not met. Anybody whose life was lost to overdose, their needs were not met, and society failed them. And really, we need to look at how to innovate that. And we've done well with opioids. We, you know, we understand it as a health condition. We treat it with medication, and we showing people dignity and respect and offering them treatment instead of incarceration time and time again. But largely, I'll save my commentary. I'll just opioids are really a crucial part of the human experience. A lot of our brain is what's what I'm looking for? There's a lot of opioid activity in our brain because our body produces its own opioids. We have endogenous opioids. The term endorphin was actually coined for endogenous morphine. When we are in pain, our body produces its own endorphins or pain relievers. So, but for about 5,000 years, people have used exogenous or external opioids or opiates from the opium poppy. Opium smoked or consumed, morphine, codeine. These are all naturally occurring opioids. You could throw kratom, the plant from Southeast Asia. That's a plant-based opioid. That's not from the opium poppy. There's a compound in most cheese called casomorphin that is an opioid. Casomorphin is present in a cow's milk to reinforce the behavior of a baby cow coming back for more milk. And a lot of cheese, they concentrate that casomorphin, and it actually binds to opioid receptors in the body and creates a response and reinforces that behavior. And so we really have a ubiquitous relationship to opioids. But when we talk about opioids, we usually think about semi-synthetics like heroin or oxycodone, or fully synthetics like methadone or fentanyl. I would argue that most of the people, everyone on this call probably knows just about as much about this stuff as I do every day. We've been dealing with this for a long time. Opioids are a depressant. They depress the nervous system from the front to the back, and they release dopamine. And dopamine is really important to the human experience because it reinforces life-sustaining activities. So when we eat food, drink water, have sex, care for our children, seek shelter, feel safe, we get dopamine, and that says that's good, do that again. But drugs like opioids or cocaine, methamphetamine, really addictive drugs, they release a lot of dopamine, and continued use reinforces that behavior as a life-sustaining activity, and we're told to do it again. And when I learned this in rehab at 25, I said, holy, why didn't anybody all I was told was that I had a disease that was incurable and I needed to find God. And like, I believe that. Like, I found God, I found Jesus, I love my life, I found much life great, and I owe it to God and my family and the community around me. But this helped me a lot. Like, this really helped me understand I have a preventable, treatable condition that can go into remission. And that this explained to me why I could, inject $100 in cocaine and $100 in heroin in a day, but I couldn't feed myself or seek shelter, or I was no longer motivated for sex or connection. I wanted to be alone and do drugs. This education is prevention. Educating young people about brain development and addiction and dependency is a lot better than saying, just say no, don't do it because this is your brain on drugs. Young people are smart, really much more smart than we give them credit for. And if you listen to contemporary music, you hear a narrative of time and time again, reoccurring and reinforced narrative in especially hip hop music. I take drugs and now I'm rich. Time and time again, when you boil these songs down, young people have a narrative of, I'm sad, I take drugs, now I'm rich. And then they're put into these situations where they're maybe going to try an opioid for the first time. They've been lied to, and they don't know about this. Not know about this or addiction or dependency. In high school, I just knew that if I didn't take an opioid or a benzo, I felt like crap. And I would drink alcohol before school to feel better. Lots of problems getting sent away, lots of issues. I was using heroin on a regular basis when I graduated from high school. I wish I learned at 14 or 12 what I learned at 25 about addiction and mental health and emotional expression and mentorship and role models and healthy coping skills, because recovery is oftentimes about finding the dopamine elsewhere. And for some people, it's jumping out of a plane or a sense of belonging in a fellowship. But opioid receptors in our body are about connection to people and pain relief. And so as we look at the opioid crisis or the overdose crisis, it's not why the painkiller, but why the pain. Why are people self-medicating to a point where they're overdosing on opioids? Largely, it's because of the drug supply. We know that fentanyl can be found in any pill or powder, but an opioid overdose is when too much of an opioid overwhelms the system and suppresses the body's urge to breathe. Essentially, an overdose can happen right away or evolve, but it's the brain being depressed from the front all the way to the back to the brainstem, and the brainstem not telling the body to breathe. This is a respiratory event. This is an event that involves lack of oxygen. And so think about that when we talk about how to recognize an opioid overdose. And the training of trainers that we're going to be doing in a few weeks really emphasizes the ability to give somebody nasal Narcan with 1 to 5 minute spiel on what they need to understand. And Thought of this morning. So recognize, respond, recover. So we want to know how to recognize an overdose. So y'all can read this. So depressed, it's a depressant. So slow down brain, slow down breathing, slow down blood. And if that's happening, use naloxone. I'm going to assume that we have done the Narcan training aspect of this. Naloxone is an opioid antagonist or a blocker. Naloxone enters the brain. It goes from the nasal mucous membranes up here in the nose to the blood to the brain. It takes about 3 minutes for that to happen. And naloxone reverses the effects of an opioid overdose and allows the brain to tell the lungs to breathe again. Very unpleasant. Getting revived by naloxone is very unpleasant. It's kind of, imagine your whole brain was shut off from the back. And then this medication comes in and turns it back on 0 to 60, but you have no memory recall, very little executive functioning. You're in an anxiety attack because all your opioid receptors are blocked and you're in withdrawal. So you're hot, you're cold, you're sweating, you're shivering, no memory recall, anxious, and you have people in your face asking you questions you legitimately don't have the answers to. Getting saved by naloxone, I'm grateful for it. Some of the worst experiences of my life. And it's really important when we're training people on how to respond to this to let them know that, like, give the brain a bit some time to turn back on. There's a lot of forms of naloxone that can be used, but for this training, it's the nasal spray, the name brand Narcan. And so if we see people who are exhibiting symptoms of an overdose, first response is to yell, verbal stimulation, and then a sternal rub or physical stimulation. And if they're not responding to yelling or a sternal rub, rubbing their sternum, we want to call 911 and administer naloxone. You peel it open, you place it in their nostril, and you press the trigger. Again, I'm assuming that y'all have learned how to use a nasal spray. Best case scenario, they regain consciousness, their breathing improves, and EMS arrives. If they respond, let them know what happened. They're not going to know. And so now's not the time for an intervention. Let them know we seek medical attention because Narcan only lasts 30 to 90 minutes. If their breathing improves, you can put them in the recovery position, put them on their side so they don't choke on their vomit. And if their breathing doesn't improve and you're trained and comfortable to have a rescue breathing mask, you can breathe for them with mouth-to-mouth resuscitation or rescue breathing. And so if we're going to use rescue breathing, we want to finger sweep, make sure there's nothing in their mouth they're going to choke on, lift their head back, 2 full breaths of your oxygen into their lungs through a rescue breathing mask, holding their nose. You'll see their chest will rise, their color will come back into their face, and you can keep someone alive like this during an overdose event indefinitely. And there are people I know personally and throughout the world who have been saved by just rescue breathing, no naloxone, no 911, just peer-to-peer rescue breathing. And so this is a really important tool to have because sometimes you don't have Narcan. But if we're teaching rescue breathing, we can save lives. And really, teaching CPR is a big part of this too, but the chest compressions is really a last resort to jumpstart the system because we're talking about a respiratory event. And typically the first thing EMS does when they arrive on the scene is use a bag valve mask or oxygen support, giving somebody oxygen until their body can breathe on their own. In a lot of countries, you see overdose prevention sites that use less naloxone and more oxygen, more bag valve masks. Incorporating oximeters into this response is important to look at, blood oxygen levels. And naloxone nasal takes 3 minutes to start working. After 3 minutes, if there's no response, second one. I know that was really fast. Does anybody have any questions on that before we chug along to the stimulant conversation? So far, so good. So overdose aftercare is really important to emphasize because going into this, it's really traumatizing, and we need to remember that people make decisions based on their circumstance and provide non-judgmental support. And remember that immediately after an overdose, there's a lot of weird stuff going on upstairs, but it's not the time to ask some questions about treatment or play the blame game or ask some questions. Give them some time. Do they want some water? Nasal Narcan tastes really bad in the back of your throat. Do they want a cool cloth? Are they hot? Are they cold? Do they want a blanket? And really treating them with dignity and respect. And sometimes less is more until they're able to. And I know this is a point of frustration for first response, because if somebody can sign their name, they can walk away from an overdose. But really, there's other interventions that don't involve criminalizing or bringing someone to the hospital. Maybe it's resources, maybe it's preparing for the next event, looking at overdose response and follow-up. And really, this conversation is a new one across the world about overdose and brain injury, because if somebody has been experiencing an overdose for 3 minutes or more, they may have experienced an anoxic brain injury from lack of oxygen to the brain. And what we see with the most chronic overdosers, the kind of repeat customers, is people living with a brain injury. And that's really eye-opening for people. I helped with a PBS docuseries, Roads to Recovery for New Hampshire, covering this topic. I work with some task forces in New Hampshire to address this, because the most important parts of the brain for a recovery from a use disorder are, the attention, memory, processing, and executive functioning, are also the most impacted by an anoxic brain injury from overdose. And the way to prevent this is rescue breathing, bag valve masks, and if somebody has potentially experienced a brain injury from overdose, getting them in front of a neurologist is really important, because they may need a different type of recovery or a treatment plan that works for them. That's a lot. I'm sure y'all know about Good Samaritan law. That's an important part of getting people to use their Narcan. How can someone reduce risk? Medications for opioids. We know that we have 3 FDA-approved medications: opioid blockers, a partial agonist, buprenorphine, and a full agonist, methadone. Methadone is still the gold standard for treating opioid use disorder, but most of New England doesn't have access to methadone. So really hoping that we sort of look at office-based methadone. And for people who don't have a positive reaction to buprenorphine or Suboxone, office-based methadone is going to save lives. And we really need to see how we can make this work with the new federal guidance for opioid treatment programs, because the methadone clinics don't work for a lot of people. They're great for some people, and I know people who will go to the methadone clinic forever and they love it. It's good for them, etc. But really, it's about giving people options that make sense for them. And so, opioid overdose prevention: don't use alone, go slow, don't mix your drugs. If you're sick, limit use, drink water, eat food, sleep when you can. Test your drugs for fentanyl and know the signs of an overdose and know how to respond. We can obtain naloxone in many different ways. Meth. I have 5 minutes left with y'all. I'm sorry I kind of beat up the naloxone stuff a little bit and the opioid stuff, but that was, going to be the meat and potatoes of that presentation. And you kind of have an idea as to what the majority of this training is. I have a lot of content on meth, probably another hour or two that I could deliver. I know I've talked with James and Stephanie about this stuff and other drug trends. I'm also connected with Ken Bradley from HIDA, talking about, how do we respond to this? And the concern is that volume-wise, methamphetamine may surpass fentanyl in coming months or years. And again, supply and demand, it's economics. People are driven by productivity and connection, and methamphetamine is really a powerful drug. It interacts really interestingly with the brain. It's metabolized out of the body in almost the same form it was put into the body. It's now available in really pure, concentrated forms. That's really not been available to New England until recent years. And what I see are people that are graduating, I'll say, from opioids to meth, because the idea is that they can't overdose, or they need to work, or it helps with withdrawal from opioids. And so at first, it seems really great. They're more focused. They have a sex drive. And for people who have used opioids for a long time, your sex drive goes away. And if you use meth and you have some crazy sex for the first time in years, that really reinforces the behavior, and people kind of chase that for a long time. They experience euphoria, energy, They may be losing weight, and like that, they may be functioning better. But over time, that use may be continued and they become disinhibited. They start to sweat. They experience anxiety. Compulsive redosing is a big part of this. Decreased circulation, dehydration, increased blood pressure. Because we're talking about a stimulant or something that wakes up or activate the brain. So faster brain, faster heart rate, faster breathing, and overheating. And so this really does a lot of things in the brain. Dopamine, serotonin, and noradrenaline. And the methamphetamine, that methyl branch, it blocks the reuptake of those neurotransmitters. And so people get high for a long time and then compulsively redose. But what describe it for people who have never used it is that it gives you the illusion of control. It shuts down the parts of the brain that drive you for survival or self-preservation, tells you everything's fine, and it increases your drive for pleasure and control. And so this is a recipe for disaster. And so we see people who are out of control going the streets on meth or bath salts or cocaine. In their brain, everything is fine. And then when we offer them treatment, we take away their autonomy and their agency and their control. And the only thing that's giving them pleasure, and go to a 28-day program, but amphetamine withdrawal is really acute for about 10 days, and then it's subacute for a few weeks, so less sleep, mood swings. This is where things are kind of dicey. 10 to 21 days since last use of meth. This is where people leave treatment against medical advice, or they can't hold their job sleeping for 14 hours a day. And this can go on for a year even. People can be not motivated for things that give them pleasure. They can be depressed, sexual dysfunction. Really, it's a long-term game, and overdose from stimulants is not like an opioid overdose. People are actively awake, and the most recent data from New Hampshire show more stimulant-related overdose deaths than ever before. Deaths from solely cocaine or solely meth are on the rise. And a stimulant overdose looks a lot of different ways. It kind of looks like somebody going crazy or hyper, but they could be hallucinating, having mood swings. They could be aggressive. They could be dangerous. And this was the norm for a lot of people in Manchester working there. They weren't aware that they're overdosing because people believe they can't overdose on stimulants, so they do way too much. Cool them down, call 911. A full overdose prevention strategy includes stimulant overdose and awareness. They're going to be dehydrated and hot, so give them water, reduce stimulus, get medical professionals on the scene, and make sure they feel safe. Because generally, if someone is freaking out on stimulants, they don't feel safe. And so you want to remove stimulus and make them feel safe and help them cool down. Harm reduction tips for meth, we give out with H2RC. I can definitely share this information. It's 11:30 on the dot. I would love to take any questions or comments y'all have. This is my contact info if you want to reach out. But thank y'all for coming today. I know I went a little bit over. I packed this with content, and I'm really glad that James and Stephanie were on the call, and curious if y'all have anything to say before we hop off. So thank you.
I just want to say thank you so much, Ryan. Over the years, I think we've gotten quite a bit of content around harm reduction and the value of certain service programs and Naloxone, but the way you put it together with your lived experience and that of the folks that you serve really just adds to it and helps to drive home that these are really important strategies to save lives and to to build people up and to try to connect them to services and resources. And I think, in so many circles, we say meet people where they are. And almost, I think, comes, I don't know, I don't want to say laughable, but people are like, oh, you keep saying that. Well, it keeps coming up because it's so important. You can't force people into something that they don't want to do. You just need to be there to support them and, try to make sure if they're still going to use substances, that they're doing it in the safest way possible, because we can't get somebody who's not alive into treatment and into recovery. And I think that at the end of the day is the most important. message that we need to drive home to partners.
So much for those kind words. I appreciate it. Thank you.
James, I think you're still on mute.
How about now? Okay. So Ryan, thank you for your information. I think you had a lot of valuable content, and you were able to get it all in there in a good amount of time. So thank you for that, and thank you for sharing your experiences. I think you serve as a great resource to all of us, specifically your background and your dedication to what you're doing right now. So I appreciate it, and thank you.
Great. Yeah, thank you for being here. I appreciate it.
Yes, thank you both. I agree. And I don't know if you see in the chat, we do have an evaluation for this part of our education. If you don't mind clicking on that and taking it, if now is not a good time, I do email it out after the talk as well. So at some point, but also we'll keep you both informed of other, like I said, we have a training on the 30th. If you have people you want to invite to that. It'll be probably a little bit different content, right, Ryan? Because this was very specific to EMS folks, but very, very similar as well. I just noticed a few nuanced changes from when, unless you're just evolving your presentation, but yeah. So we look forward to getting more people involved in this training, but also in the Train the Trainer. If you, I know Stephanie, you have very strong connections in the community. So if you know of a champion who might be interested in becoming a trainer of this information, we'll take referrals as well. So, but yeah, excellent job, Ryan. I think you bring the human component to this very difficult topic, and that's what's really needed if we're going to make a difference in preventing overdose deaths. So, great job, everyone, and thank you all, and more to come as well.
Awesome.
Great. Take care, everyone.
All right. Thank you. Good presentation, Ryan.
Thank you.
Great job.
Yeah, definitely stay in touch on future stuff, and I hope you all have a good weekend.
You as well.